So welcome. My name is Hannah Gilbert. I am the director of ABSAC, the American Professional Society on the Abuse of Children. I am so excited that you all are here for our 4-week journey through primary, secondary, tertiary, and universal child abuse prevention during April Child Abuse Prevention Month. We have Dr. Catherine Taylor, who will go ahead and kick us off today with primary prevention. I want to remind you all that we have three more sessions after this. It's all the same Zoom link. We have secondary prevention on April 16th with Rhonda Newton. April 23rd will be tertiary prevention with Dr. Cheryl Langtree. And April 30th will be universal prevention with Stacy LeBlanc. And want to go ahead and just give a quick ABSAC update. A lot of you are members, and this is a free event. If you are not an ABSAC member, we do encourage you to join. We have tons of different ABSAC member benefits, including free and discounted trainings, member-only sections, and resources. With that said, we also have our annual colloquium coming up in June 9th through 12th in New Orleans. You can scan the QR code. We would love to have you here. And I'm based in New Orleans, there are 13 tracks with tons of different speakers and a lot of New Orleans fun. And with that, I am going to go ahead and introduce Dr. Catherine Taylor, who I'm so excited is here today. So Catherine Taylor has been a professor at Boston College School of Social Work since 2020. She completed her MSW and MPH at Boston University and then trained at UCLA School of Public Health and Community Health Sciences, Epidemiology, and Media Studies. She went on to be a postdoctoral scholar at Columbia University School of Social Work and focused on the development and assessment of preventive interventions to prevent child abuse. She then joined Tulane University School of Public Health and Tropical Medicine in New Orleans as faculty, where she became the founding director of their Violence Prevention Institute and Pincus Violence Prevention Scholarship Program, and developed their first course on violence as a public health problem. Her research is focused on the primary prevention of trauma and violence, especially that which impacts children, via testing and implementing preventive interventions and understanding the important and complex role of social norms in this arena. She's also focused on optimizing access to and translation of scientific evidence, as well as the uptake and implementation of evidence-based practice to promote mental health, treat trauma, and prevent violence. Thank you so much, Kathy, a wonderful mentor. So glad to have you here. If you all have any questions, we will have a question and answer at the end, so please feel free to put them in the chat.
Hello, everybody. Hannah, thank you so much for that lovely introduction. Great. Can everybody, Hannah, how's it showing? Perfect. Great. Well, welcome everybody. And again, thank you so much, Hannah, for that introduction. I'm really happy to be speaking with all of you about this topic that is so important, I know, to everybody here, to myself. It's an area that I've been working on for about more than 20 years. So I'm happy to be here to talk about it with you all today. So I'm going to focus on primary prevention of child abuse, and I'm going to especially be coming from a public health approach to this topic. So I have a few questions that I'd like all of you to keep in mind that we're going to revisit at the end of this talk. So the first question, can child abuse be prevented? What are the different ways to prevent child abuse, and how can I contribute to preventing child abuse? In other words, I especially would like you to think through this talk about things that I talk about that resonate with you, that connect with your job, that are areas where you think you could be making a direct contribution to primary prevention of child abuse, because all of us can. So the first question, I'm sure you all know the answer to this or we wouldn't be here. Of course, child abuse can be prevented, which is wonderful news. If you have not already accessed this fantastic free document from the CDC, I highly recommend it. It is honestly still one of my go-to documents when it comes to looking up really great strategies and information about child abuse and neglect. So this is free on the CDC website. And So we know we can prevent it, but of course the big question, or one of the big questions, is how. And with that, I'm going to kind of walk you through a public health approach to how I think about this issue. So we're going to talk through some key steps like defining the problem, choosing risk factors to address, or how do you choose which risk factors to address, how to develop prevention strategies, or how to choose which prevention strategies to use, what is the spectrum of prevention, and then I'm going to give some program examples for us to talk about. So the public health model, just briefly for those of you who are not familiar with it, the first step in the public health model is always to define the problem. So in our case, that just means how prevalent is child abuse in our community or in this country, and who is most at risk. So basically, how big is the problem? How do we want to qualify the problem, and who is impacted? So one of the things that I think can be kind of confusing about defining the problem is that when we look for statistics about child abuse, sometimes we can find all kinds of different statistics and not really be sure what the difference is between them or how you should choose the statistics to pay attention to that are right for you for whatever reasons you're looking for them. So given that issue, I'm going to run through 3 examples that I think are really nice examples of ways of tracking and understanding the problem of child abuse, how big of a problem it is, particularly in the United States, in different ways that we can assess it, and therefore make informed choices about the kinds of statistics that we refer to when we're trying to define the problem. So the first example I'm going to refer to is the document that I'm sure many, if not all of you, are familiar with, Child Maltreatment, which comes out annually, can be found for free, of course, on the Administration for Children and Families website. So this is the latest version of that. So that's going to be my first example. The second is going to be a representative sample, a nationally representative sample done through survey by David Finkelhor and his team. And the third example I'm going to use of defining the problem or doing surveillance for child abuse is to think about the Adverse Childhood Experiences Study, which of course the original study was done many, many years ago. We're going on almost 30 years now. But the study was important for a lot of reasons. And so, of course, many of those statistics not only endure from the original study, but have been replicated or re-examined in different populations and in new studies. So with that in mind, when you're trying to decide, which of these should I be referencing, which apply most to the issues that I'm interested in or that I'm dealing with, these are the kinds of questions you want to ask yourself before you choose which type of report to focus on. So one is just, how were the cases identified? Who is reporting the information? What's the time frame of the abuse? What's the time frame for the reporting itself? And how was abuse defined in that particular report? So for example, if we go back to that first example of the child maltreatment document or the NCANS data, we know that that report is very specific to Child Protective Services reports as they are reported from the states and through state agencies. Also, those statistics and that data is really incidence data, meaning it just references the past year new incidents of child maltreatment, right? So of course you can be comparing incidents over the years by looking at all of those reports sequentially. And then in terms of the time frame of reporting, it's really focused on, again, just prospectively, what has happened within a 1-year time frame. And the way that child abuse is defined in that study is very specific, right? If we're looking at substantiated cases, which tends to be the stats that many of us use, then that is defined, of course, by states and state law. If we move on to statistics provided by something like, or try to define the problem through something like the Finkelhor study, which was a national household survey, the numbers are going to look quite different, right? Because instead of these numbers being based on what was reported to CPS and that was what was found to be substantiated, It's really a national survey that was done where the reporters were actually children and or caregivers. There were reports that reflected both the past year dynamic of abuse as well as a lifetime retrospective reporting of abuse. And the behaviors that were assessed were quite limited in scope, or fairly limited in scope. They were not terribly broad. And so given that, if we compared the rates to the first type of report and the second one, the rates that we would find in this nationally representative sample, of course, would be much higher than the rates that reported by NCANs of substantiated abuse. And then, of course, if we want to go even broader than that, we can start to look at ACEs, right? And so for those of you familiar with the ACEs study, I'm sure it's almost all of you, stands for Adverse Childhood Experiences, and tended to ask very, yes or no questions, and assessing very broadly different types of abuse in childhood, as well as different types of household dysfunction, intimate partner violence, use of substances, mental health issues with parents. And in that case, at least in the original study, that was a very specific sample, right? That was just from an HMO in Southern California. Of course, many, many other studies of ACEs have been done now in different samples in different populations. And so we would expect the numbers to be quite different, right, for ACEs, depending on what population we ask those questions in. But generally, the reporters are the adult victims actually reporting retrospectively on their entire childhood. Behaviors are broad. And again, because for all those reasons, the statistics, when you read about the prevalence of child abuse from ACEs studies, is the highest of all three of these types. So I just bring this to your attention because it can be hard to figure out or make sense of all the different numbers that we see when we're trying to define the problem. And I think hopefully this kind of framework can help you to think about which types of reports you want to look to and which types of numbers you want to report, depending on the purpose of what you're doing. So once you have defined the problem, the next thing, and the next two areas, what we're going to spend most of our time on today, very important, of course, then to think about what are the risk factors for abuse, right? So identifying the risk and protective factors is the second big step in the public health model. So when I think about identifying risk and protective factors, I really like to reference the social ecological model. It's a very simple model. It's not complicated, but I think it's really helpful to remind us that there are factors that impact how people parent that happen at multiple levels, right? So of course, there are things that happen at the individual level, how the person thinks, their own attitude, their own skills, their own inherent characteristics. But there's also a number of factors that are very influential at things like the family level, the relationship level, the community level, and even the broader societal level, for example, social norms or laws. So given that, we're going to walk through some of the things we know about some of the key risk factors in particular at each of those levels. And by the way, this information, much of it is readily available through the CDC, which I think does a really nice job of tracking, what's the latest in terms of what we know about these risk factors. Frankly, again, I've been working in this area for more than 20 years, and most of the risk factors really haven't changed, right? So we've understood most of these for a long time. So things like characteristics of the person, such as if they're younger, if they have many children, low education or income, if they themselves were abused or neglected as children. Also at the individual level, things like drug or alcohol abuse, mental health issues, depression, lack of knowledge about children's development, high levels of stress, use of corporal punishment. So you may have noticed that for these individual risk factors that I'm sure everyone is familiar with here, or most of you are, you'll see that I kind of separated them into two groups. And in the chat, I'm wondering if anybody wants to take a guess as to why I separated these into two groups. What's the difference between the top four and the bottom? So I'm not going to monitor the chat, but while you're thinking about that, that's totally fine. Basically, the big difference that I see is that the ones in the bottom are the ones that I'm going to focus on as somebody who is interested in prevention, because these are characteristics or factors, risk factors that are modifiable or potentially amenable to change, right, through intervention. So those are the ones that I am going to have us focus on throughout. And I would suggest that as you're thinking about prevention, those are the ones that are especially helpful to focus on. So similarly, if we think about the family level, relationship level, having a household member in jail or prison, caregiver being isolated, lack of connection, presence of intimate partner violence, negative high conflict communication styles, none of these are new, right? But again, when we're thinking about prevention, we know how important it is to tackle things like social isolation, lack of connection. By the way, also an extremely important risk factor for many types of violence, right? So having some sense of not feeling connected to folks, not feeling supported. And of course, having intimate partner violence or other types of violence exposure or high conflict is really the opposite, right? Because those types of things tend to create a sense of disconnection. Okay. And at the community level, of course, all of these different things can be risk factors. So again, it's things we've heard before: high rates of poverty, high rates of violence and crime, low educational opportunities, unemployment rates, low collective efficacy. So essentially feeling like folks in the community are not really looking out for each other, or there's low involvement in the community. So you can imagine, if you start thinking about prevention, that which level of the social ecological model you are working in is going to somewhat drive which of these risk factors that you address, right? So if you are somebody who is working, let's say, in city government or state government or federal government, you might be especially focused on these types of things. How can we reduce rates of crime across the population, rates of poverty, improve employment rates, right? So those aren't necessarily something that folks, let's say, working in an agency or more in one-on-one settings or social service settings would have much ability to change, right? So moving on to actually talking about prevention strategies, because this is the part that I think is, of course, the most interesting. You guys already know there's a problem and there's different ways to look at it. We've known about the risk factors for a long time. Where we really have our work cut out for us, though, is prevention strategies. I think the good news is that we actually do know how to prevent child abuse, but making it happen, implementation, execution, right? That's the biggest challenge, or that's one of the biggest challenges. So given that, let's just start by talking about the kinds of things that we want to think about when we're developing prevention strategies. So first thing that I always think about when I'm thinking about prevention is, given that there is this long list of risk factors, what I need to figure out what to focus on, right? If I'm interested in prevention, I can't possibly tackle all 50 of those risk factors. It wouldn't make sense. But how can I prioritize, and how do I make that decision? Well, of course, one way that you can prioritize is just based on the work that you personally do, right? So if you're already doing work in some of those areas that we talked about as risk factors, then you have your priority named for you. However, if you're thinking about developing a new strategy or particular strategy, you always want to start by thinking about, again, is the risk factor that I'm interested in changing modifiable? Is it strongly associated with child abuse in your community and population of interest? So it always really helps to have some data that supports that that particular risk factor is of a particular issue in the community that you're working in. and similarly, is that risk factor highly prevalent in your community or population of interest, right? Because if you focus on something that has a strong association with child abuse and it's highly prevalent, and you try to reduce that risk factor, then you have a really nice chance of potentially reducing rates of abuse or preventing abuse in that community. Last but not at all least, unfortunately, is you have to ask yourself, is it feasible to change? So many times, very real issue in our work, right? Is it fiscally possible? You might have fantastic ideas about how to address drug and alcohol issues or all kinds of other issues on that list. But if you don't have the finances for it, if it's not fiscally feasible, then you have to look to something else, right? And I would argue, frankly, out of this whole list, that the biggest thing we need is the political will to do these things, because we actually know how to prevent child abuse. The question is, how do we marshal interest? How do we marshal, the attention of folks when there are so many things in our society that are vying for attention, right? That are looking, where folks are looking for funding, looking for support, trying to change things. So this, I think, is one of our biggest challenges. So once you have made a decision about, based on those factors, which risk factors you want to target, you also want to think about who you plan to target or address prevention with, or essentially what I mean by who is what risk level. Are you going to focus on folks? Are you going to focus on everybody? Meaning you're developing a prevention strategy that is focused on educating everybody in a community without any attention to whether they are at risk or not, to try to change norms and how people think in a community. Are you going to take a selective approach, meaning that you're going to focus your resources on folks that have been identified as at risk for abusing? Or are you going to focus on what's called, by the way, these are public health terms used specifically for these different types of groups, and how you'll just make a decision about how big you're going to go in terms of your focus of your intervention, or how narrow. So in this case, indicated would be if you're working, let's say, with folks who had been, let's say, caregivers where there had been substantiated abuse, and they were, the prevention strategy or intervention strategy was designed for them. So in terms of when you will intervene, so here's where we get into the concept of primary, secondary, and tertiary prevention, which is the theme of the month, is working through these levels, right? So what do they mean? So a lot of times these levels get confused with these levels. So universal, selective, and indicated are really referring to the population that you're working with. Are you talking about a universal population, a selective population, or an indicated population? When you talk about primary, secondary, tertiary, usually what you're talking about is the timing of when you're hoping to intervene. So primary prevention generally refers to when you're taking an approach where you hope to address the violence before it has ever occurred. So prior to any kind of initial perpetration or victimization. So for example, if you, actually, I'm going to get into some examples in a minute. So let me just first go through these three. So that's primary prevention. Secondary prevention tends to refer to when you are addressing an issue such as violence, such as child abuse, pretty much immediately. So in the short term. So an example of this would be like a CPS report and CPS response. Tertiary tends to refer to when you're dealing with the longer term consequences of abuse. And so this might be things like mental health treatment, trauma-informed therapy. And I'd like to say, though, that I think even though certain things in that moment are noted as secondary or tertiary, each of those steps, of course, can in their own way serve as primary prevention strategies, right? Since we know that if we can provide effective treatment and deal with the consequences of abuse for folks who have experienced it, then we can also reduce their risk of abusing at a later time, right? So each of these, this isn't about one being better than the other. They are all on a continuum. They all feed into one another, and they're all important. So just to give some specific examples of these, so primary prevention, so examples that I think of, and an area that I tend to focus on a lot is how we educate parents. In particular, for primary prevention, it might be, if you want to get really technical, you might focus on first-time parents, so you know that they haven't yet had any experience where they've been challenged in raising their children. But really, any kind of parenting education classes where you're trying to prevent child abuse from happening through the education that you're doing, or just general public education. So public education campaigns, information about not hitting children, such as through no-hit zones, which we're going to talk about a little bit. Secondary prevention, as I mentioned, could be something like CPS intervention if abuse is suspected, or in a no-hit zone, it would be the example of a bystander intervention, right? So what that means is that, let's say that somebody working in a hospital where there's a no-hit zone, they see somebody who is hitting their child. So secondary prevention would be that bystander coming in and intervening, right? And trying to, and essentially trying to redirect and help that parent, right? So that that doesn't escalate. Tertiary prevention, again, could be things like mandatory parenting classes for folks that have, where substantiated abuse has been identified, or treatment for trauma, CBT, trauma-informed, could be an example. So anything where you're actually taking care of the longer term consequences of abuse. Okay, so now we're going to talk about how we will actually target risk factors, right? So we've talked about thinking about risk factors and what types they are, how you prioritize, who or what levels of risk groups you would be interested in targeting, when primary, secondary, or tertiary prevention. Bigger question is how, right? Once you have those other things identified. So again, I'm going to send you back to this amazing resource. If you haven't already seen it, you probably have, but they have absolutely wonderful guidance in this resource around different types of strategies and approaches. This is one of their key tables that I have often referenced that I really appreciate, where they really tie together strategies that are tied to many of those risk factors and then flipping those to their protective factors, and then tying those strategies to specific approaches. So example, there are things like strengthening economic support for families, right? Since we know that low income, living in poverty can be a huge risk factor. So that's an incredibly important strategy. Also changing norms to support parents. So essentially finding ways at a more societal or community level or even organizational level to change people's attitudes and understanding about the use of hitting children, to try to end the feeling that it's necessary to hit children, and also at the same time educating parents around positive parenting strategy, nurturing parenting strategies, and parenting strategies that are not harmful. So this type of work can be done through public engagement and education campaigns, legislative approaches, and I'm actually going to talk a little bit more about those as we move forward. But other examples of strategies: providing quality of care and education, enhancing parenting skills through home visitation, and also intervening through things like primary care and parent training programs. So these are the two areas that I'm going to spend a little bit more time on and go into some very specific examples. These are the two areas that I have spent the most time in. And I just wanted to show here this nice alignment between what the CDC is talking about and recommending in terms of prevention and what Prevent Child Abuse America is noting on their website. You'll notice at the bottom there, they talk about policy change, they talk about home visitation programs, public awareness and engagement. So we all are on the same page about the types of things that we need to do to help children. So when I think about specifically what types of programs I want to, or interventions or programs I want to work with, or how I want to approach a problem, from a public health perspective, I really, really appreciate the spectrum of prevention. One of the things that I like about it is I think it leaves no stone unturned in that there's this whole spectrum. It essentially highlights that there's a whole spectrum of things that we can do to focus on to prevent child abuse. And frankly, I don't think any one of these is any more important than the other. The longer I've worked in this, the more I've seen that each of these levels is often very much intertwined. In other words, often in order to get policy or legislation passed, you have to do a great job fostering coalitions and networks, educating providers, educating the community for that to happen. Similarly, the more you strengthen individual knowledge and skills, the more you're likely to change some of the more top-down approaches. And of course, if we do manage to change policy and norms and organizational practices, that can also then influence the folks that are, let's say, living in that community or working as part of a particular organization that, let's say, has a no-hit zone or has set up some kind of a new organizational strategy to promote positive parenting and not harming children. So as an example, I'm going to focus on, for a minute, on what would policy and legislation look like. That would be an example of primary prevention. So I'm actually going to start at the global level. And Hannah, if it's possible, I'm going to ask people to respond in the chat. And I'd like you to put in the chat, without Googling the answer, how many countries do you think have banned corporal punishment? Meaning, how many countries have enacted federal bans on the use of corporal punishment?
We have a 0, 2.
Don't be shy, everybody, because this is not a quiz. You're not going to get graded. This is really just for me to see what you guys think. Not as, okay, so I'm reading through this and it's really fascinating because, Hannah, correct me if I'm wrong, I'd say the average guess is somewhere around 5 to 10 at the most, maybe less, probably closer to 5, right? Wonderful. Thank you, everyone, so much for giving your guesses. So you all are going to be a little bit surprised, except for that one person who guessed 64, because the answer is actually 65. Universal bans on corporal punishment have been put in place in 65 countries over the past 4 decades. If you look at this chart, this graph, you'll see that it has really accelerated since the year 2000. I'm just going to credit Liz Gershoff for that. I know it's a lot more than that, but point being, I think that the science as well as children's rights efforts, which have been so important globally, have really helped to move this effort forward. Of course, the UN Convention on the Rights of the Child has been a huge part of this because that is actually how many of these countries have been, what they've been referencing in terms of setting up this ban. Obviously, having a ban or having a law and having it implemented and actually, happening as stated, those are 2 different things. However, again, from that kind of top-down approach or thinking about legislation and policy, this kind of, this helps to set a tone in a country that this behavior is not acceptable. I often liken it to, where we have been in our country when we started finally passing laws against, like the intimate partner violence, right? Or we started taking intimate partner violence much more seriously. Once those laws were in place and much more, people were paying attention to them more and realizing that intimate partner violence wasn't something that people could just get away with. Note that it did not eliminate intimate partner violence, right? But it certainly had a big impact on people realizing this is not something that is acceptable, and this is something that will receive intervention. So if you're interested in learning more about global efforts, I think it's important. I find understanding what folks around in other countries are doing is really helpful, because we have our own little bubble where we think this is how it is. And when you look outside and you see what other countries are doing, you realize there's a lot of different ways to address things. And so if you're interested in the global efforts, this is a great website. It's actually called End Corporal Punishment. The link is at the bottom. You'll have access to this in the recording, and this is their latest report. As far as policy and legislation goes in the United States, probably the most significant thing to talk about in terms of primary prevention in child physical abuse, which is the area that I'm focusing on, I should have mentioned that, is that, so there's no federal level prohibition of corporal punishment in schools. However, there are 31 states in the country where corporal punishment is considered unlawful in schools, in public schools, and 19 states where it is considered lawful. So there's a breakdown of that. So point of bringing this up is that you may be thinking, well, we're probably not going to get to a federal ban on anything anytime soon in the US. However, we do tend to have a lot more success in the United States at the policy and legislation level if we work at the state level. Okay. Now I'm going to move into talking about some examples of programs, and I'm going to weave in, as we talk about this, how it links back to other things we've talked about in the presentation today. And I'm also going to leave time for questions and discussion, because I'm looking forward to that. So the first couple so these are just examples. Of course, I'm not giving a comprehensive list, but the first couple I'm going to mention, I consider two of the gold star interventions, in that they have so much evidence behind them. Both of them in terms of primary prevention of child abuse. So I'm sure everyone has heard of Nurse Family Partnership. There's also Healthy Families America. There's multiple types of home visiting programs out there that have a lot of evidence. So when we go back and ask the question, what are they targeting? So of course, remember we talked about the importance of preventing social isolation. So a big part of this program is providing social support. It's also increasing knowledge of child development, improving parenting skills. So if they were using corporal punishment or planning on it, or struggling with providing a safe, stable, nurturing environment, this program is designed to help parents with that. So this program I would consider primary prevention, but mostly focused on individual level factors for change. So in terms of the who, right, if you remember those circles that we talked about, universal, selective, and indicated, tends to focus on, have a selective. In other words, what I mean by that is, unfortunately, we do not offer home visiting programs in the United States to everybody who wants them, right? It's narrowed down to certain groups that are considered to be at higher risk, right? So that's what I mean by selective. Primary prevention, it's established before there's an indication of violence or abuse. And in terms of the levels of spectrum prevention, I think this is kind of a fun example of showing that, of course, it addresses the individual level, but also the nurses and everyone involved who's actually doing the home visiting has to be trained, right? So there's education and providers. And of course, through the ACA, that actually helped to expand the use of home visiting programs throughout the country. So policy was very much, and legislation was very much involved in this spreading as well. Triple P is another program that does address primary prevention. It addresses probably actually all three levels that we're talking about. But again, I'm tending to focus on primary prevention. Triple P has lots and lots of studies. What they tend to focus on, or what this program tends to focus on, is really has some similarities, or can have some similarities, to home visiting. Proactive discipline and guidance, nonviolent parenting skills, increasing child developmental knowledge, setting expectations, parental self-care. So we can think of that in terms of, a huge risk factor for child abuse, as we know, is stress, parenting stress, different kinds of things that can cause parent stress. So really trying to build in those self-care mechanisms and ward against stress as much as possible for anything that can be controlled at that level. And of course, how to set up a safe and positive learning environment. When we think about who Triple P targets, again, which of those circles, what's interesting about Triple P, as many of you may know, there's multiple levels. There's 5 levels. So levels 1 and 2 are actually available universally where this program is available. And then levels 3 and 5 tend to get more and more narrow in their focus and tend to offer more intensive services. So generally primary prevention, although, so primary prevention is definitely the main focus. And there's different ways that Triple P intervenes depending on which level you're at. I'm going to spend the last bit of time that I have here talking about a couple of what I'm calling innovations in primary prevention of child physical abuse. These are 2 that I have done work with and have studied. And, we need all the positive and evidence-based interventions out there that we can get. And I think these 2 have an interesting approach that I really like for a number of reasons that I'll mention. So Play Nicely, if you haven't heard of it, and most of you probably have not, is a discipline program that was actually developed by a pediatrician. His name is Seth Scholler. Been working with him for quite a while now. And he has developed a program that essentially talks to parents about different types of parenting discipline strategies, and parents in that process get feedback about whether the strategy tends to be, so he's a pediatrician, so it tends to be recommended by pediatricians, therefore it's considered healthy for children. Does it have mixed results depending on how you implement it? An example of that might be timeout. Or is it considered absolutely not recommended? And of course, that would include things like hitting children, yelling at them, shaming them. So few things that are neat about this program. It can be done online. I'm going to be giving you guys links so you can access the online version and check it out if you want. But there's also booklet versions that currently, I believe, are mostly being used in some pediatric offices, but you can get information from this website to learn more about how you could access these programs. I'm calling this an innovation because there's still work to be done in terms of the evidence. However, there's lots of information out there already to show that it has shifted attitudes around parenting, attitudes around, that it's not a good idea to hit children. In addition, I have been working on a study for, let me mention, these are the 20 different types of discipline that are covered. So parents get feedback about things that are great options, good options, and then not recommended options. And again, it could either be through the video tutorial or through a booklet form or through conversation with a pediatrician or another healthcare provider. Oh, sorry, I've just confused myself. So yeah, so Play Nicely, I'd say it's mainly working on the strengthening individual knowledge and skills level. From some of the research that I've done, I can tell you that from our qualitative findings, that parents in this group, when we compare it to other groups who did not get Play Nicely, specifically talked about learning things like better communication increasing, use of corporal punishment decreasing, or doing that less. And the really nice thing is we also have quantitative data where we've shown that when we compared Play Nicely to the control group, that at short-term and at long-term follow-up, so short-term meaning 3 months after receiving Play Nicely, long-term meaning 4 to 5 years later, those in the Play Nicely group exhibited less coercive parenting than those in the control group. And in the short term, also had some positive parenting improvements. I can share this with you all. This is just a quick table, but that's the gist of those findings. And then the last one that I'm going to share is another one of my favorite innovations, and that's no-hit zones. I'm not going to go into lots of detail about this because I'm pretty sure that this is going to be covered in the 4th week with Stacy LeBlanc. I see Hannah agreeing with me, I think. So I will not go into lots of detail, but what I just want to mention, especially for those of you who won't be at the last one, is that no-hit zones is a relatively new, also still working on the evidence-based program, but that I think has amazing potential. It works especially at the changing organizational practices level. And here's the website. You can check it out for yourself, nohitzone.com. What I find really interesting about it is it does work on multiple levels. So it has 3 intervention components. The first component is a policy change. And I wrote here as an example, like no hitting allowed in a hospital, but it could be a school, it could be a church, it could be a city, but it could be a store, it could be Walmart. But essentially, there's an agreement at the organizational level to have this policy change where no hitting is allowed. So establishing that norm, kind of a mini ban, if you will, at an organizational level. The second component is actually a staff training where people who work for that organization, the school or the hospital, or at the state government, they're trained about the policy. They're trained about the effects of hitting children on child health. They're trained about alternative forms of discipline, and they're trained about how to intervene. So essentially, it's not just policy change, but it's also a bystander intervention. And last but not least, there is also a broad education effort, meaning that for those organizations that implement this, there are also parenting education materials that are shared, posters, brochures, pamphlets about nonviolent parenting. So you're really getting the potential for intervention and change at multiple levels, which can be really powerful and reinforcing. There's some research on this. It's actually kind of hard to do research on this program for a number of reasons, but I worked on one of the first evaluations of this with Liz Gershoff and some others where we essentially found that that medical center staff that implemented a no-hit zone were able to do it. So they supported the implementation. And that also after the implementation, they were more supportive of intervening when they saw a child being hit. And they also knew more about how to do that and felt more confident in doing it. And last, there's a more recent study that we actually worked on that is really the first to specifically evaluate the staff training program itself, or one version of the staff training. And we found essentially that it was very successful and a lot of changes, like changing attitudes around staff, changing their confidence in wanting to intervene, their knowledge level, their acceptance of the policy, et cetera. So both of those papers are available. If you cannot find them, I'm happy to send them to you. And I'm going to end on this slide. I promised you I would come back to these questions. So I think we answered the first one, that we know that child abuse can indeed be prevented. We've covered a lot of different ways to prevent child abuse, including different levels to consider, different types of risk factors, who you're targeting, when you're targeting it, and how. And the thing I want to leave you with and challenge you all to think about is how can you contribute to preventing child abuse? I'm anticipating that every single person on this call is doing something related to any one of those risk or protective factors. And I would love to hear your thoughts and just thank you for your attention and for being here.
Thank you so much, Kathy. There are several questions that have come through in the chat, and feel free, everyone, to put in more. One is going back to factors that you can address earlier on. Why can't low income and lack of education be changed?
Yeah, that's a great point. I was sort of hesitating when I when I said that. I think it's a great point that I think it can be changed. Yeah. I'll have to be careful about how I say that for. I just want to say, yes, I do think it can be changed. I just think maybe I had in mind that it's one of the harder things to change, or it might be typically changed through agencies that tend not to be focused specifically on child abuse. I think that's what I was more of my point, if that makes sense.
Absolutely. No, thank you for the clarification.
Yeah.
So another question, how does delayed disclosure of abuse affect the time-based levels of intervention? If a child discloses abuse a year after the abuse happened, is a follow-up response to that disclosure still considered secondary prevention?
Oh, interesting. I would consider that still secondary. I mean, really, the primary versus secondary versus tertiary, rarely are you asked to put what you're doing in a category. It's more to say that there is a spectrum at which we could intervene. If I had to guess, I would put it somewhere in the secondary to moving towards tertiary prevention. But either way, you're addressing the child's needs. Always better later than never, right? So that's fantastic.
Absolutely. And then there was a comment going back to political will.
Yeah.
So Gwen Downing, which I do want to shout out for giving this wonderful idea of doing primary, secondary, tertiary. She said that I think one of the strategies is helping people remember or become aware of our interdependence. So that's one comment that was put in the
Yes.
chat.
Can you say more? What I love that. I'm so with you. Please say more.
So, a lot of times people, and I'm going to use some generalizations, especially in America, have that we're very individualistic society. Um, and I live in Oklahoma, so I think that's very strong in our culture of, yes, we believe in community, but it's a very individualistic society. And we forget how interdependent we are. For example, this whole Zoom thing, we aren't creating the electricity or anything else. And so everything we all do at any given time is impacting each other. And a lot of times people see a child being abused as something happening over here. And when we talk about our ecological models, there's that interdependence of how whatever's happening to that child is impacting the ecological system, and that ecological system then goes back to that child. And so there's that loop always of how all of us and what's going on is connected.
Amen. I couldn't agree more, really. And yeah, I couldn't say better. I really agree. I think one thing I was going to add to that is that it makes me remember when I was early days in my first faculty position at Tulane, and was reading up a lot about ACEs studies. And it was kind of everybody was talking about all the things that ACEs are related to, all the things that everybody cares about. And I remember talking to many folks in my department who worked in all of those areas: heart disease, smoking, pregnancy prevention, all these issues. And public health professionals, were surprised to know that there was this connection between what I did and what they did. And so I think we even have work to do amongst ourselves, right, around that sort of education of interdependence, like you were saying, Gwen. And then, as you also said, much more broadly beyond our profession.
What about, do you have any recommendations about how to address the concept of primary, secondary, and tertiary prevention when writing grants?
I, probably an annoying answer, but I think it really depends, right? And particularly, so for example, when I wrote a grant to the CDC, they specifically said they were most interested in primary prevention. And so usually when you're writing a grant, in my experience, the funder will say what their priority is. And so if you are working in a place where you have the ability to choose between primary, secondary, and tertiary, I would, of course, this is not going to be rocket science to anyone, but I'd focus on what, mainly what the funder wants if you can do that. So I'm not sure I'm answering the question. Maybe some clarification if there, or the person could also feel free to just hop on and chat with me.
Sorry, it took me a second. I guess sometimes I get a little tripped up with, they don't overtly say whether, I guess you've armed us with some more information about distinguishing. So I guess I can read in better now as to what they are looking for in terms of that level. I guess my point was that I just get a little tripped up sometimes when a grant will say, kind of blanket statement, no prevention. And I'm like, well, but there's different ways of looking at that, like you talked about with primary, like some of it is that kind of that walking that line. We're doing an intervention and prevention. So I don't know.
So you have funders that say will fund treatment but not prevention, for example?
Yeah, maybe something like that.
Okay. Honestly, to me, it's all about framing. It's know your audience. I feel like every time I write a grant, that's my first, who's my audience? Because just like to this audience here, I have some idea of my audience. And part of why I'm saying, that primary, secondary, tertiary are related is because we understand that loop, right? But if your audience is saying no prevention, only treatment, then I would just leave the word prevention out of it, and focus on the fact, but you can feel good knowing, hey, we're offering treatments, we're serving people directly. This could also influence prevention. I think I can't say for sure from the example you've mentioned, but my hunch is if they're saying no prevention, they're saying, to focus the funding on direct service. Yeah. More so than trying to prevent bad things from happening. But if only we could all, we have our work to do to get the message out and the political will strengthened, that actually, if we could prevent more, then we could save a lot of money, but it's
fair. No, that's a great answer. I think that's a good, I think it's more about me changing mindset. When they say no prevention, I think I need to just change my mindset and just say, okay, I'm going to reframe it so that I'm not saying the word prevention, but I know what I'm doing. So perfect. I
yes, like that. Yes. You know in your happy heart that you are preventing, even if they don't care.
So. Exactly. Thank you very much.
Yeah, of course.
See Mr. Gordon's hand up, and then we will wrap up.
Oh, thank you for letting me drop in. This audience ought to know that within the month, the U.S. Preventive Services Task Force published in the Journal of the American Medical Association a policy statement saying there was no proof that intervention, primary prevention, and primary care had any effect on child abuse and neglect. And you should be aware that their studies were limited to a very small sample of very highly defined controlled studies having a control group. They mostly involved home nursing visits before to high-risk families. And what they really said was, we don't have enough long-term studies to show that they actually did anything. It doesn't say that nothing was accomplished. So everybody should be aware if that subject comes up to take it with a grain of salt. And it's really academic constraints and rigid rules that prevent them from supporting what we've all just learned today.
Yes, I'm sighing because yes, I mean, I've been trained as a scientist and researcher, but I'm very aware of the constraints. And so thank you for bringing that up, because we have to be, it helps to be able to critique what has been done and what the limitations are. So thanks for your point, really important.
Thank you so much. And we will share this recording, and we hope that you will join us in 2 weeks with secondary prevention.